This is a picture test in practical anatomy. You may use the video as a revision for the topic or as a self-assessment tool. For the purpose of self-assessment, pause the video and spend your own time to read the question and come up with the answer. Then replay the video to confirm your answer and listen to the comments and explanations. Which superficial vein is this? What is its origin? Where does it drain into? This is a superficial vein on the lateral side of the forearm, and we can see here that it is close to the roof of the anatomical snuff box. It is the cephalic vein. It is one of the two main veins, the superficial veins of the upper limb. A superficial vein is located in the superficial fascia and is not accompanied by an artery, like in the case of deep veins. So there is no artery accompanying this vein. The cephalic vein arises from the lateral end of the dorsal venous arch on the dorsum of the hand. It passes proximally on the lateral side of the limb to drain eventually into a deep vein, which is the axillary vein in this situation, that is located at the root of the limb, that's to say in the axilla. So it has to pass through a deep fascia, and so the cephalic vein passes through the deep fascia, which will be the clavipectoral fascia located at the deltopectoral groove between deltoid and pectoralis major. Passing through this fascia, the cephalic vein drains into the axillary vein. This is a patient with wrist injury exposing the bones of the forearm. List two bones articulating with surface A and name two bony landmarks at the distal end of bone B. Now A is the distal end of the radius, which articulates with two carpal bones. From lateral to medial are the scaphoid and the lunate to form the wrist joint. B is the distal end of the ulna. It has two bony features, this distal end of the ulna, the head of the ulna that articulates with the distal end of the radius at the distal radio-ulnar joint, and the other feature is the styloid process of the ulna. Identify the tendons marked by the probe A. On which joints do they specifically act? And also identify the tendon B. Name the synovial sheath which surrounds the tendon. This is a deep dissection of the palm, where the fibrous flexor sheaths have been removed. Each fibrous flexor sheath extends from the metacarpal head to the distal phalanges. So they are removed here, exposing the contents of the sheath, which are the tendons of flexor digitorum superficialis and flexor digitorum profundus as far as the medial four fingers are concerned. We can see here that the tendon of flexor digitorum superficialis enters the sheath on the palmar side of flexor digitorum profundus, and the superficialis tendon divides into two halves near the base of the proximal phalanx. These halves, they flatten, they spiral around the profundus tendon to be inserted into the margin of the middle phalanx. The tendon of profundus, which is tendon A, passes through the split in the tendon of superficialis to be inserted into the base of the distal phalanx. So from a deeper position to a superficial position, passing through the split in the tendon of superficialis. Being attached to the distal phalanx, it will be in a position where it can specifically move the distal interphalangeal joint, while the tendon of superficialis being attached to the middle phalanx can move the proximal interphalangeal joint but not the distal interphalangeal joint. So tendon A, flexor digitorum profundus, specifically acts on the distal interphalangeal joint. Now in the case of the thumb, the fibrous flexor sheath is occupied by the tendon of flexor pollicis longus alone. B is therefore the tendon of flexor pollicis longus. Now the tendon of flexor pollicis longus is surrounded by a synovial sheath, as well as the tendons of the other digits, but here this is a special synovial sheath for the tendon of flexor pollicis longus. This synovial sheath extends from a finger breadth proximal to the flexor retinaculum all the way continuously to the insertion of the tendon at the base of the distal phalanx. There is no interruption. Now you know that a synovial sheath is needed to reduce friction and increase mobility. The synovial sheath of the flexor pollicis longus, which is sometimes called the radial bursa, communicates with the common sheath of the superficialis and profundus tendon, which is sometimes called the ulnar bursa, in about 50% of the cases. Infection of the synovial sheath, which is called tenosynovitis, might result from introduction of bacteria through a pinprick. This will cause distension of the sheath with pus, and the finger will become swollen, semi-flexed, and any attempt to extend it will be accompanied by extreme pain since the distended sheath is stretched. Identify the muscle A, what is the nerve supply? Identify the artery B, what is its origin? Muscle A is a thin quadrilateral muscle that lies most superficial over the hypothenar eminence. It is relatively unimportant. It probably wrinkles the skin of the medial side of the palm and deepens the hollow of the palm. It is supplied by the nearby superficial branch of the ulnar nerve. This nerve, the superficial branch, is mainly cutaneous. As you can see here, it supplies the medial 1.5 digits, the skin over the medial 1.5 digits, and it sends a branch to the muscle, the palmaris brevis muscle. Otherwise, the superficial branch of the ulnar nerve is cutaneous. B is a vessel that is a branch to the thumb. It arises from a deep artery that is located here between the two heads of Adductor Pollicis. This is the radial artery. As it leaves the anatomical snuff box, it passes between the two heads of the first dorsal interosseous muscle and then the two heads of Adductor Pollicis muscle. The artery, the radial artery, will give a branch which is called princeps pollicis. It divides into two branches to supply the thumb, as its name indicates, and also it supplies another branch. You can see it here. The branch will continue to supply the radial side of the index. That's why it's called the radialis indicis. And then the radial artery will continue to form the deep palmar arch after joining the deep branch of the ulnar artery. A 40-year-old patient presented with a tiny painful tumor under the nail bed of her thumb. Which nerve is responsible for the cutaneous innervation of the operative field? 3 nerves participate in the cutaneous innervation of the hand. The ulnar nerve, as a whole, supplies the palmar and dorsal aspect of the medial third of the hand and the medial 1.5 digits. The superficial branch of the radial nerve is a purely cutaneous branch that supplies the skin of the radial 2/3 of the dorsum of the hand and the radial 3.5 digits, but proximal to the nail beds. Thus, it doesn't supply the nail bed of the thumb, which is operated on in this patient. The third nerve that provides cutaneous innervation of the hand is the median nerve. The median nerve supplies the skin of the palmar aspect of the lateral 3.5 fingers, including their nail beds on the dorsum, and thus including the area of operation here. It should be remembered that the exact cutaneous areas supplied by these 3 nerves, median, ulnar, and radial, are subject to variation and overlap. Point tenderness in the anatomic snuff box region should always alert one to the possibility of a fracture of which of the following bones, A to D. First, let's identify the bones. A is the base of the second metacarpal bone. B is a carpal bone on the second row next to the trapezium. You can see here the trapezium articulating with the metacarpal of the thumb, and the bone next to it, B, is the trapezoid. The bone medial to it is the one with a big head, the capitate. the largest of the carpal bones. C and D belong to the first row of carpal bones. Both articulate with the distal end of the radius at the wrist. C is the most lateral. It is boat-shaped and it is the scaphoid bone. D is the lunate bone. The anatomic snuff box is a shallow triangular depression on the dorsolateral aspect of the wrist. It is visible when the thumb is extended. In its floor can be felt the styloid process of the radius, the scaphoid bone in addition to the trapezium, and the base of the thumb metacarpal. Now, tenderness in the snuff box is an important sign of fracture of the scaphoid, which is the most commonly fractured of the carpal bones. So the answer here is C. Which tendon is shown? What is the nerve supply of the muscle? This is the tendon of flexor pollicis longus muscle. The muscle belongs to the deep group of the flexor muscles of the forearm. It arises from the radius, and the tendon is formed on one side of the muscle, giving the muscle a unicipital shape in the forearm. Being a member of the flexor compartment of the forearm, it is supplied by a branch of the median nerve, by the anterior interosseous nerve. Remember that forearm flexor muscles are all supplied by the median nerve, except 1.5 muscles. A 20-year-old lady presented with a pain in her wrist after she fell hard on her outstretched hand while she was skating. Radiological studies confirmed dislocation of a proximal row carpal bone that articulates with the radius. Which of the carpal bones shown in the image was most likely dislocated? The carpal bone most commonly dislocated is the lunate bone. This is a member of the first row of carpal bones. Now let's identify the bones here. A is the trapezium that belongs to the second row of carpal bones. Bones from B to E belong to the first row. B is the boat-shaped scaphoid, followed medially by the lunate C, and then D is the triquetrum, and E is the pisiform bone. So the answer here is C, the lunate bone that is most likely dislocated in this patient. Identify the nerves A and B. Name the canal through which the nerve B passes. This is the ulnar nerve. It enters the palm on the ulnar side, lateral to the pisiform bone and superficial to the flexor retinaculum. The ulnar nerve divides into superficial and deep branches. The deep branch supplies hypothenar muscles as it passes deeply through them. Now, as the ulnar nerve is located in the depression between the pisiform and the hook of the hamate, the depression is converted into a tunnel called Guyon's canal. It is converted into a tunnel by a ligament called piezohamate ligament extending from the pisiform to the hook of the hamate. This ligament has been removed in this dissection. Thus, the ulnar nerve may be compressed as it passes into this fibro-osseous tunnel, resulting in what we call ulnar canal syndrome or Guyon's tunnel syndrome. So the ulnar nerve might also be compressed. The deeper branch of the ulnar nerve might also be compressed, although the ulnar nerve does not pass through the carpal tunnel like the median nerve, but it can be compressed while the deeper branch of the ulnar nerve passes through another tunnel. The superficial branch A supplies palmaris brevis, which is a thin quadrilateral muscle that is most superficial over the hypothenar eminence, and it has been removed from here. The superficial branch is mainly cutaneous, and it supplies cutaneous branches to the medial 1.5 digits. And of course, these extend to supply the nail beds on the dorsum of the hand as well. Note here that the ulnar artery has been pulled away to expose the divisions of the ulnar nerve. But the ulnar artery is the main contributor to the superficial palmar arch. Which of the muscles A to E is usually supplied by the ulnar nerve? And name two other muscles of the palm supplied by the ulnar nerve. First, let's identify the muscles. A and B are thenar muscles. A is abductor pollicis brevis and B is flexor pollicis brevis. B is medial to abductor pollicis brevis, and both have a similar attachment to the lateral side of the proximal phalanx of the thumb, where a sesamoid bone is located in the common tendon of insertion. C is the adductor of the thumb. It is adductor pollicis, no longus, no brevis, because there's only one adductor muscle. While, for example, for the flexor pollicis brevis, there is a flexor pollicis longus, which is a member of the deep group of flexor compartment of the forearm. And for the abductor pollicis brevis, there is an abductor pollicis longus, which is a member of the deep group of muscles of the extensor compartment of the forearm. But we have only one adductor pollicis, which is C. You can identify adductor pollicis since it is in a deeper plane than A and B. It is located in the web between the thumb and index finger. Thus, it is in a position where it is inserted into the medial side of the base of the proximal phalanx of the thumb, and thus can adduct the thumb as its name indicates, adductor pollicis. D is the first lumbrical muscle. Lumbricals can be identified by their elongated worm-like forms, from which the name lumbricals is derived. They are attached to the tendons of flexor digitorum profundus. The tendon of profundus is not shown here because it is covered by the flexor digitorum superficialis. Also note that this and other lumbricals pass to the radial side of the proximal phalanges of the fingers. E is a tendon of flexor digitorum superficialis. You will expect that the tendon of profundus lies deep to it and is completely obscured by the superficialis at this location. Now, regarding the nerve supply, A and B, being thinner muscles, are supplied by the recurrent branch of the median nerve. This is the median nerve, and this is the site of its recurrent muscular branch. The recurrent branch also supplies opponens pollicis, and then the median nerve supplies branches to the radial lumbrical muscles. So the radial two lumbrical muscles are supplied by the median nerve. Remember that in the forearm, the medial half of flexor digitorum profundus is supplied by the ulnar nerve together with flexor carpi ulnaris, but the lateral half is supplied by the anterior interosseous branch of the median nerve. So the lumbricals originating from the tendons of flexor digitorum profundus have a similar pattern of nerve supply to their mother flexor digitorum profundus. The two lateral lumbricals are usually supplied by the median nerve, and the two medial lumbricals are usually supplied by the ulnar nerve. So D is the first lumbrical, and thus it is supplied by the median nerve, not the ulnar nerve. E, being a tendon of flexor digitorum superficialis, the muscle is supplied by the median nerve in the forearm, and again it is not supplied by the ulnar nerve, and it is also not supplied by any nerve in the hand. C is the only labeled muscle here that is usually supplied by the deep branch of the ulnar nerve. So apart from the 5 intrinsic muscles of the hand supplied by the median nerve, all the other muscles in the hand are supplied by the ulnar nerve, including all the interossei, palmar and dorsal interossei, the medial two lumbricals, and the hypothenar muscles, flexor digiti minimi, abductor digiti minimi, opponens digiti minimi, as well as the small palmaris brevis muscle. All are supplied by the ulnar nerve. When the ulnar nerve is injured, adduction of the thumb is lost because of paralysis of adductor pollicis, which is supplied by the deep branch of the ulnar nerve. If the patient is asked to grip a piece of paper between the index and thumb, the patient will do so by flexing the thumb rather than adducting the thumb. This is what is clinically known as Froment's sign. The patient can still flex the thumb because the long flexor muscle, flexor pollicis longus, is supplied by the anterior interosseous nerve from the median nerve in the forearm, and flexion is also performed by flexor pollicis brevis, which is supplied by the recurrent branch of the median nerve in the palm.